Patients with brain metastases are a difficult group and they're heavily underrepresented in clinical trials. This is even more so for patients with symptomatic brain metastases. In the Checkmate 067 study, for example, only 3.5% of patients assigned to Ipi/Nivo had brain mets. So although this issue is widely acknowledged, it remains an area of undermet, if not still, frankly, unmet need. One of the key principles in our current approach to patients with melanoma brain metastasis is to spare them whole brain radiotherapy wherever possible. We've really only been able to do this in recent years due to the availability of effective systemic therapies with intracranial efficacy. But the increasing access to stereotactic radiation approaches and its use for increasing numbers of separate lesions has also given us more options for local control that don't involve whole brain radiation. The management approach partly depends, in my mind, on the status of extracranial disease, the location and or number of brain metastases, as well as whether the patient is symptomatic or asymptomatic from the brain metastases. So patients with multiple sites of disease, inside and outside the brain, or even multiple brain lesions, even if they're individually only small, will likely manifest new sites of disease in short order, and for that reason really warrant prompt institution of systemic therapy. The preferred regimen in patients with brain metastases is ipilimumab plus nivolumab, which we know from Checkmate 204 has activity in asymptomatic patients, where there was a 53.3% intracranial response rate and a 3-year overall survival of nearly 72%. To a lesser extent, it is active in symptomatic patients. So that same study showed a 16.7% intracranial response rate in symptomatic patients and a 3-year overall survival substantially lower at 36.6%. Many of those patients, of course, are on immunosuppressive doses of steroids. The phase 2 ABC study confirmed greater efficacy of the combination over single-agent nivolumab, with 46% versus 20% intracranial response rate in all patients. And I think those data have really led to the adoption of the Ipi/Nivo combination as the standard of care first-line therapy in this scenario. The response rate to Ipi/Nivo appears numerically superior to that seen with first-line dabrafenib and trametinib targeted therapy in BRAF mutant patients, of course, but noting that the targeted therapy only applies to patients with BRAF mutant disease for whom differences in the underlying biologic behaviour of their melanoma brain metastases might also be a factor in the differences in outcome. Patients with very limited intracranial disease may be suitable for upfront stereotactic radiation to all sites of disease. However, because patients more often than not have concurrent extracranial sites of disease, systemic therapy is usually instituted around the same time. It's not yet known whether there is any benefit from upfront SRS in conjunction with immunotherapy or whether reserving stereotactic radiation for later, if and when it is needed in the event of intracranial progression, leads to better long-term outcomes. And that question is currently being evaluated by the ABCX study. Now, some patients have no detectable extracranial disease. A select few of those may be suitable for local therapy to their limited intracranial disease, followed by observation only. The motivation for observation alone in these cases is largely to delay the need for systemic therapy and thereby avoid treatment-associated side effects, which we know are very common and can be quite significant with the combination immunotherapy regimen that is preferred for this group of patients. So a good example is the patient who presents with neurological symptoms or even a surveillance scan detected solitary brain metastasis after a long disease-free interval. And for reasons of symptom control and or confirmation of the diagnosis, some of these patients will actually proceed to a metastectomy with or without postoperative radiation to the resection cavity, and they can be rendered free of evident disease. So these patients might elect to be observed postoperatively rather than immediately commencing systemic therapy with sort of adjuvant intent, because it would be done in the context of no evaluable disease, which makes it very difficult to balance toxicities against an uncertain degree of benefit. There is now data supporting the use of adjuvant immunotherapy, as discussed previously, particularly ipi-nivo, in resected stage 4 patients. However, I think further work is needed to clarify whether there is meaningful benefit from adjuvant therapy for this rare group of completely resected stage 4D patients, as the data to date are very, very limited. And I think finally, I can't fail to mention immunosuppression. So it's a key factor in the personalisation of brain metastasis management. Patients with symptomatic brain mets clearly have inferior outcomes, lower response rates, poorer survival to systemic immunotherapy. In large part, we attribute this to the fact that symptomatic patients are often on moderately to very high doses of corticosteroids to control vasogenic edema and symptoms prior to initiating immunotherapy. And the immunosuppressive effect of steroids can hinder activation of an effective anti-cancer response. If the steroids cannot safely be weaned, ideally below our generally accepted threshold of 10 milligrams per day prednisolone equivalent, prior to starting immunotherapy, then it might actually be worth considering whether first-line targeted therapy in BRAF mutant patients at least is warranted. In such cases, the intention is often to get rapid control of disease and then switch to immunotherapy as quickly as possible. But with that strategy, it is important to consider the implications that could have on drug access and future lines of therapy based on local regulations and PBS wording. So studies are also ongoing to determine if there are safe steroid-sparing alternatives that could be effective for symptomatic control in brain met patients without compromising immunotherapy efficacy. There's some preliminary data that suggests that bevacizumab may be one such steroid alternative, and this is being further investigated by the BETTER study currently.